esteemed members of the faculty, also esteemed members of the organizing committee, and dear delegates, a very good morning to all of you. This is a topic that is dear to Dr. Mahesh's heart. This is a huge and confusing topic, but yet it is very vital for all of us. And in the time that is allotted to me, I'll try my best to present to you a bird's eye view covering all the salient points. To begin with, certain vital statistics. Across the world, approximately 31.5 million non-cardiac surgeries are performed each year. And 10% of these are performed in the US alone. And of these, 42% are inpatient, whereas 58% are outpatient surgeries. Now, it is interesting to note that in the last 20 years, the overall perioperative morbidity and mortality in these patients from cardiovascular complications has dipped only very marginally from 3.1% to 2.6%. 45% of patients presenting for non-cardiac surgeries have two or more cardiovascular risk factors, and in 24.3% of patients, there is a cardiovascular disease that is secondary to accelerated atherosclerosis. And the cost of preoperative testing in the US alone amounts to $18 billion per annum. Now, prior to last year, we were guided by this guideline that was issued by the American College of Cardiology and the American Heart Association in 2014. Now, as per this guideline, there was an emphasis on estimating the functional capacity of the patient, risk stratification, and selective non-invasive testing with the aim of uncovering silent myocardial ischemia such that we do not have any surprises in the perioperative period. And late last year, we came up with this guideline. Now, as you can see, the inputs are much more broader. Besides the AHA and the American College of Cardiology, you also have the American College of Surgeons, the American Society of Nuclear Cardiologists, the Heart Rhythm Society, the Society of Cardiovascular Anesthetists, and so on. Now, as per this guideline, which is in vogue today, there has been a paradigm shift from emphasis on routine preoperative ischemia testing, because today there is data which has emerged to state that uncovering myocardial ischemia in the preoperative period has not actually significantly altered the anesthetic plan or the incidence of postoperative cardiovascular complications or the rates of myocardial infarction. So there has been a shift from an impetus on risk stratification to identifying the risk factors and optimizing these risk factors when time and opportunity present themselves. Now, all of you know about the recommendations and the strength of the evidence. Now, the strength of recommendation can go from class 1 to class 3. And evidence can go from level A, which is the strongest level of evidence, down to level C, which is based on expert opinion. Now, when we look at surgeries, we classify them as urgent surgeries, emergency surgeries, time-selective surgeries, and elective surgeries. Emergency surgeries typically are performed within 2 hours of the patient presenting to the hospital. This is because there is a danger of the patient losing the life or limb in case of a delay. Urgent surgeries, on the other hand, can be performed between 2 to 24 hours after presentation to the emergency. So there is some time for preoperative evaluation and possible stabilization of the patient prior to wheeling into the theater complex. Time-sensitive surgeries are those that can be delayed for about 3 months from the time of presentation with an effort to pre-optimize the patient's cardiac status. Elective surgeries can be delayed indefinitely without affecting surgical outcomes. Low risk surgeries are those where combined surgical and patient characteristics predict the low risk of major adverse cardiac events of less than 1%. When it exceeds 1%, this is an elevated risk surgery. Now, there is something also called a surgery specific risk. Now, low risk surgeries include cataract, cosmetic, and plastic surgeries. Those surgeries where risk is between 1 and 3% would include most orthopedic surgeries, ENT surgeries, and genitourinary surgeries. Those with a slightly more enhanced risk of between 3 and 5% would be general abdominal and intraperitoneal surgeries, as also neurosurgeries. And these surgeries that are to follow have the highest risk. Suprainguinal and peripheral vascular surgeries account for a complication rate of 7.7%, thoracic surgery is 6.5%, and transplant surgeries is 6.2%. This was a meta-analysis that was published in 2014, looking at about 55,000 liver transplant recipients. And about 40.2% of all mortality that occurred in these recipients within 30 days of surgery were attributed to cardiovascular complications alone. Now, when we take a patient with surgical pathology into the theater, intraoperatively, as anesthetists, we know that we face several physiological challenges. There are hemodynamic perturbations, there is sympathetic activation with subsequent release of catecholamines, there is cytokine production and hypercoagulability, which is quite typical of the perioperative period. Now, all of these can combine to give us ischemic myocardial injury, which is either secondary to an acute plaque rupture or mismatch between oxygen supply and demand. You can also have fatal arrhythmias and acute decompensated heart failure. Now, there are certain broad contraindications to non-cardiac surgery, which include patients with recent acute coronary syndromes, acute decompensated heart failure, tachy or bradyarrhythmias requiring medical attention or presenting with significant hypotension, or a symptomatic severe aortic stenosis with a mean gradient that exceeds 40 millimeters of mercury, wherein the luminal diameter of the aortic valve is typically less than 1 square centimeter. Now, when this patient presents to the anesthetist for a surgical evaluation, we do what we call the pre-anesthetic checkup. And that begins with both a comprehensive history to rule out or confirm the presence of ischemic heart disease, a coronary stent, heart failure, arrhythmias, valvular heart disease, systemic or pulmonary hypertension, chronic kidney disease, and diabetes, amongst other systemic comorbidities. And when we talk about physical examination, we focus exclusively on murmurs. Dr. Srinath spoke about those. We focus on diastolic murmurs or systolic murmurs that are exceeding a grade of 3/6. We also have to listen for gallop rhythms, which is an S3 or an S4. Sometimes S3 and S4 fuse to give us a summation gallop, jugular venous distension, basal lung crepitations, pedal or generalized edema, or resting oxygen saturation that is close to or below 90%. Functional capacity is an independent predictor of preoperative morbidity and also perioperative morbidity. Therefore, it is important for the anesthetist to evaluate the functional capacity of each patient. If the patient can independently perform their daily activities or chores, that is equivalent to 4 METs. A MET is a metabolic equivalent of task, for the sake of juniors in this audience. You can also resort to the more complex Duke Activity Status Index. Now, based on functional capacity, the patients are divided into dependent, partially dependent, or totally independent. So, poorer the functional capacity, more the problems in the perioperative period. Since I am pushing 63 years of age, if anyone tells me that old age begins at 65, I will vehemently disagree. Age is just a number. I think it is the presence or absence of frailty that makes the difference. I mean, there are so many frailty scores that one can resort to, but all we need to look at is the patient's physical build, gait, speed of ambulation, and balance. And that gives us a certain indication on whether the patient is frail or not. Assessing frailty is important because data is emerging today to support the utility of both nutritional rehabilitation and exercise in improving outcomes in these patients following non-cardiac surgery. Frailty is typically associated with age above 75 years. In these subset of patients, there is a decreased sympathetic response to stress, also reduced vascular compliance, impaired baroreceptor reflexes. There is cardiac diastolic dysfunction in most of these patients. Symptomatic aortic stenosis becomes more and more prevalent with advancing age, and these patients are also prone to non-cardiac complications such as perioperative infections, respiratory failure, or perioperative acute kidney injury. Now, after having assessed the patient in terms of history and physical examination and assessment for functional capacity and frailty, we look towards risk stratification, because risk stratification helps the anesthetist quantify perioperative risk. And the American Society of Anesthesiologists Physical Status Classification is an excellent index. And as per a particular meta-analysis, it has been revealed that the possibility of perioperative cardiovascular complications is less than 0.1% in ASA grade 1 patients, going to as high as 18% in ASA grade 4 patients. And these, as we know, are the sickest category. Now we move on to the other risk stratification indices, the oldest being the Goldman Index of Cardiac Risk, which was unveiled to us in 1977. Though there are so many indices, at this point of time, there is no evidence to support one index over the other in terms of superior predictive discrimination. We tend to follow the revised cardiac risk index, which is based on 6 criteria: ischemic heart disease, cerebrovascular disease, history of heart failure, insulin therapy for diabetes, serum creatinine wherein the level exceeds 2 milligrams per deciliter, or a planned high-risk procedure. Now, for all of these criteria, 1 point is assigned. The patient with the lowest risk is one who does not have a single of these 6 criteria. And when the patient has 3 or more criteria, they carry the highest risk for perioperative complications following a non-cardiac surgery. A 12-lead ECG is useful, especially in a patient who has arrhythmias, or when we uncover a pathological Q wave, ST segment depressions, left ventricular hypertrophy, a QTC prolongation, or a bundle branch block. It does not have any benefit in asymptomatic patients undergoing low-risk surgical procedures. A routine preoperative resting 12-lead ECG is not recommended to improve outcomes. But for asymptomatic patients undergoing elevated risk surgeries with known cardiovascular disease, a preoperative 12-lead ECG may be considered to establish a baseline and guide perioperative management. Now, two-dimensional echocardiogram is also useful in those patients with known or symptoms suggestive of following, which is heart failure, valvular heart disease, known left ventricular systolic or diastolic dysfunction, known congenital cardiac disease, or those with pulmonary hypertension. In asymptomatic and clinically stable patients undergoing non-cardiac surgery, there is no benefit in routinely evaluating preoperative LV function in the resting state. As far as 1996, that was so many years ago, the AHA-ACC perioperative assessment for non-cardiac surgery guidelines clearly indicated that routine preoperative stress testing was not warranted. In spite of that directive, this particular study showed that approximately 50% of patients with no cardiac risk factors undergoing total hip or total knee arthroplasties had preoperative stress testing. So this is a complete non-adherence to the prevailing guideline. As for this current guideline is concerned, there is only a class 2B recommendation for stress testing in elevated risk patients with poor or unknown functional status. A CT angio is performed quite often. In fact, I get one every 5 years. And this is useful only in those patients where we wish to uncover significant high-risk coronary anatomy. That is, more than a 50% occlusion of the left main coronary artery or more than 70% occlusion of the 3 main coronary branches. But in patients who are at low risk for perioperative cardiovascular events, having a good functional capacity with stable symptoms, it is probably not advised. It has a very high negative predictive value in the sense that if the CT angio is normal, then we can take it for sure that the patient's coronary anatomy is okay. But if the patient does have a lesion, it is likely that a CT angio overestimates the risk, and then we will also have to follow up on these patients with the traditional invasive angiogram. Now, biomarkers have come in and made a presence in this particular guideline. Now, we have brain natriuretic peptide or an alteration of BNP, which is called N-terminal pro-BNP. These are peptides that are released by the cardiac myocytes in response to atrial stress. And you also have cardiac troponins, which are an indicator of myocardial injury. Now, in patients with known cardiovascular disease or age above 65 or age above 45 with symptoms suggestive of cardiovascular disease undergoing high-risk non-cardiac surgeries, it is reasonable to measure both BNP as well as cardiac troponin in the preoperative period. And there is a new term now in the new guideline, which is myocardial injury after non-cardiac surgery. That is, if we compare the preoperative ECG to the immediate postoperative ECG, there are fresh changes in the ECG. And in this patient population, it has been advised that we do a surveillance with cardiac troponins once every 24 hours for the first 48 hours. Coronary stents, we all know, we delay a non-cardiac surgery for 2 weeks following a balloon angioplasty, for 30 days following the placement of a bare metal stent, and 12 months following a drug-eluting stent in situ. But today, data is emerging to state that maybe 4 to 6 months' time is enough after placement of a drug-eluting stent. Now, with this background information, let us look at the algorithm. A patient with cardiovascular risk factors is scheduled for non-cardiac surgery, and it is an emergency surgery. So there's absolutely no time. So we proceed with surgery after having counseled the patient and the family. But if this patient is not presenting for an emergency surgery, then we do a thorough perioperative risk assessment. So during pre-op evaluation, we look at the history, the physical examination, we assess for functional capacity and frailty. We look at the type of surgery, whether it's a low risk, intermediate risk, or a high risk surgery, and then we use a verified risk calculator. We typically use the revised cardiac risk index to be able to stratify the extent of perioperative risk. Now, if the patient has a low calculated risk, we proceed with surgery. But if the patient has an elevated cardiac risk, it is advised that we do a 12-lead ECG. In most instances, the patient's 12-lead ECG is already done. And the next question we need to ask is there a poor functional status or frailty? If no, we proceed with surgery. If yes, then we need to ask ourselves whether a further testing will impact decision making. If the answer is no, we proceed with surgery having explained the risks and benefits to the patient and the family, or when time is available, we optimize risk factors, or if the patient's family is unwilling, we offer them non-surgical alternatives. And finally, if the patient is very high risk, then we will have to offer a 2D echo and also consider a cardiac stress testing. So with this, I'll just present and wrap up with 3 surgical case scenarios. This is a 58-year-old male weighing 92 kilos with history of hypertension and diabetes since 10 years, with bilateral knee joint arthritis with restricted physical activity, posted for right total knee replacement. I mean, this is a daily bread and butter scenario. We evaluated the patient, we said we can go ahead with surgery, but the cardiologist was involved by the orthopedic surgeon. They performed a 2-dimensional echocardiogram and we went ahead. Now, this is a 62-year-old female weighing 122 kilos with a BMI of 44.3, hypertension and diabetes for 26 years, poor blood sugar control. Quite lately, patient was diagnosed with obstructive sleep apnea, is on domiciliary BiPAP. Room air saturation was only 84% when we evaluated the patient. So this being a bariatric surgery, there was no requirement to rush through. We referred the patient to a cardiologist. A 2-dimensional echocardiogram was done. The mean PA pressures were bordering around 40 millimeters of mercury. This patient was placed for 6 weeks on a combination of ambrisentan, which is an endothelin antagonist, and also tadalafil, which is a phosphodiesterase inhibitor. And when she came back to us, the echo was repeated. The PA pressures had come down, the peak pressures had come down, the systolic pressures had come down to less than 25, and the room air sats had gone up to 92, and we were able to do the surgery. Now, in this case, it was a 40-year-old male, chronic smoker. He had an abnormal ECG on routine evaluation, investigated with CT angio, followed with a routine traditional angio. A drug-eluting stent was placed to overcome a lesion in the ostial LAD 4 months ago on dual antiplatelet therapy, and this patient presented with an acute abdomen. So there was no time to consider anything. We explained the risk to the family, we spoke to the surgeon, we put in an arterial line for monitoring. We did a crash induction on this patient because this was an acute abdomen. We did a laparoscopy, and a very inflamed appendix that was about to burst was taken off. Local peritoneal toilet was done, a drain was placed. The patient did well and got discharged after 2 days. So thank you very much for your attention, and apologies for just about crossing the time limit. Thank you.